Hello, my name is Teresa. The mental health issue I chose to focus on is access to mental health care. I believe access is the foundation of mental wellness because without it, people can't get early help or learn how to prevent a mental crisis. There are still big gaps in care, especially in rural, low-income, and minority communities where zip code insurance or culture often decides who gets treatment. When access is limited, people rely on emergency rooms or end up in the justice system, which is not built for mental health needs. Better access supports prevention, chronic disease management, and healthier community outcomes overall. As a future nurse, I see mental health care as a basic human right, and no one should have to struggle to receive the care that they deserve. In this little short presentation, I'll briefly discuss how access affects healthcare quality, safety, financial costs, policies, and what nurses can do to advocate for change. According to the World Health Organization, better known as WHO, limited access to mental health care directly worsens client outcomes, as when people face long delays or go untreated, especially in conditions such as bipolar disorder, depression, or schizophrenia, they often become harder to stabilize, raising the risk of mental health crises, psychotic episodes, psychiatric hospitalizations, suicides, and long-term disability. The National Alliance on Mental Illness, better known as NAMI, explains that many patients end up relying on emergency departments instead of consistent outpatient care, which fragments treatment and raises the relapse rates. A study by Schwartz and their colleagues that was published earlier in 2025 showed that opening a behavioral health community clinic led to a 10% reduction in 30-day psychiatric readmissions and a 28% reduction at 1 year, demonstrating how improved access strengthens recovery. NAMI also reported that marginalized groups, including racial and ethnic minorities, rural residents, and people without insurance, face even greater barriers. These gaps contribute to a higher rate of disability, substance use, and housing instability. According to the National Library of Medicine, poor access disrupts the continuity of care, causing missed appointments, medication non-adherence, and higher hospital readmissions. WHO adds that untreated mental health conditions worsen chronic illnesses such as diabetes and cardiovascular disease, which shows how mental health and physical health are closely linked. A review by Dolly Wallendang in 2024 found that poor mental health access led to an 8.3% increase in emergency visits at 30 days and a 13.5% increase at 1 year, along with lower client satisfaction rates and higher healthcare costs, weakening the quality of the entire system. WHO states that limited access to mental health care directly affects client safety. Individuals with untreated schizophrenia have a lifetime suicide risk of 5 to 10%. And untreated depression can raise suicide risks up to 20 times higher than the general population. NAMI explains that individuals with untreated bipolar disorder may also engage in risky behavior or act impulsively, doing things like recklessly driving, substance use, or displaying behaviors of aggression, all increasing the risk of injury to themselves and others around them. WHO notes that those who do not receive care are more vulnerable to being assaulted, robbed, or exploited due to poor decision-making, judgment, or social isolation. Family safety is also impacted as well. Mental Health America describes how caregivers supporting someone without mental health treatment often develop stress, anxiety, and depression themselves, leading to caregiver strain. When there are no crisis resources, families typically call the police, which can escalate and turn into a dangerous situation, causing a traumatic encounter. Roberts adds that family violence or neglect can also rise during unmanaged psychosis, manic episodes, putting partners and kids at risk. Children in these homes might also experience trauma, neglect, or parental separation if they end up in protective services as their parents cannot keep them safe. Mental Health America reports that healthcare workers are also affected. When people do not have access to outpatient services, they typically show up in the ER in severe crisis, agitated and unmedicated. And since nurses are the frontline staff, they typically face more assaults, harassment, and threats. The CDC reports that nearly 48% of all non-fatal workplace violence injuries happen in healthcare, with many of them being mental health crises. Caraca and Moore said that repeated exposure to this kind of violence leads to burnout, missing more days of work, and a high turnover rate within the profession, making the entire system a lot less efficient and less safe for both us and our patients. At the community level, poor access means more people with untreated mental illness end up getting arrested rather than getting treated. NAMI said that about 1 in 4 individuals who are in jail right now or in prison have a serious mental health disorder that was not treated while they were residing within the community. Roberts also pointed out that untreated depression contributes to homelessness, which raises the risk for injuries, infections, and victimizations. When stigma and lack of resources keep people from seeking help, they wait until they have a full-blown mental health crisis, which creates an unsafe and unpredictable environment for themselves and everyone around them. Looking at the financial impact of poor mental health access, NAMI states that out-of-pocket costs for therapy, psychiatry visits, and medications can reach thousands of dollars per year, especially for those who are uninsured or underinsured. Caraca and Moore explained that when people cannot afford early and consistent treatment, they end up relying on the repeated hospital admissions and emergency visits, which cost a lot more than regular outpatient care. Who notes that financial hardships often forces clients to put rent, food, and basic needs ahead of their own mental health treatment, facing even more costs, especially, eviction fees, legal bills, and repeated arrest fines, making the recovery process a whole lot more challenging. On a broader level, untreated mental illness costs the United States about $193 billion each year in lost earnings. In Indiana alone, Taylor and their colleagues reported a study where they found a $4.2 billion annual burden that was tied to lost workplace productivity, higher healthcare costs, and justice system expenses. Homelessness related to poor mental health access also raises costs for emergency shelters, public safety, and emergency medical services. NAMI pointed out that jailing individuals with mental issues is actually more expensive than providing community-based treatment, yet so many communities still rely on the criminal justice system instead of investing in these mental health services. Who adds that poor mental health access also makes chronic illnesses like diabetes and heart disease worse, leading to more complications, and that also results in higher hospital readmissions and higher medical costs. Okay, looking at the laws, policies, and reimbursement factors shaping our mental health care, we have the Mental Health Parity and Addiction Equity Act that was passed in 2008. This was meant to make sure that insurance plans cover mental health care at the same level as physical health care. Mental health advocates, however, stated that while this improved coverage for many people, the enforcement was still very inconsistent, so insurers often found ways to deny the claims or loopholes to benefits or limit the benefits. The Affordable Care Act made mental health an essential health benefit and expanded Medicaid, helping millions of individuals gain coverage. However, for states that did not expand Medicaid, they still have higher uninsured rates and worsening mental health outcomes. In 2022, the launch of 988 Suicide and Crisis Lifeline gave individuals a mental health emergency option that was outside of 911. This was better equipped for mental health crises, thus improving immediate responses. But the funding for mobile crisis teams and long-term follow-up was still not enough, as described by Mental Health America. And then lastly, we also had the Olmstead Supreme Court decision from 1999, which confirmed that individuals have the right to receive mental health services in the least restrictive environment, such as a community-based environment. But since many states do not fund these community options enough, this leaves a lot of our patients in hospitals and jails. And then reimbursement is also another challenge, as Medicaid and Medicare often pay mental health providers less than our physical providers, which discourages them from taking these insurance plans. Private insurance companies also limit access with the narrow networks and heavy prior authorizations. So experts report that these laws and policies, while they have improved mental health coverage on paper, the weak enforcement, funding gaps, and workforce shortage still limit the true access to mental health care. So mental health policy experts recommend stronger enforcement of parity laws so the benefits actually match the physical health coverage. Expanding Medicaid in all states would help close the coverage gaps. Raising reimbursement rates could encourage more mental health professionals to join in on providing care to the Medicaid Medicare patients. Consistent long-term funding for the 988 system, plus culturally responsive and trauma-informed services, and collaborating with interprofessional care to reduce fragmentation and improve outcomes would also support early intervention and better continuity for care. As professional nurses, we also have a crucial role in improving mental health access. Per Dhaliwal and Dang, nurses can all provide holistic screenings for mental health concerns and barriers, starting with little things as transportation, costs, understanding barriers and stigmas, as they can all early identify and prevent escalation into emergencies. Mental Health America describes how nurses educate clients and families about available resources, insurance benefits, and community health programs to improve treatment engagement. Schwartz and their colleagues explained how nurses can coordinate care with social workers, case managers, and behavioral health providers to ensure follow-up appointments, medication access, and crisis planning. Again, just talking to your primary care providers, the interprofessional collaboration. And Taylor and their colleagues stated that nurses can also advocate at the policy level by contacting legislators, joining professional associations, or sharing data on how coverage gaps and reimbursement challenges affect patients. Joining professional organizations is something that student nurses can also do. WHO highlights that nurses support culturally competent care and trauma-informed care by working with interpretive services and building trust with underserved groups. ATI also supports this by stating that nurses use therapeutic communication, motivational interviewing, and planning client-centered goals to build a supportive relationship, encouraging them to engage in treatment for the long run. And lastly, Roberts and other mental health experts that we have discussed, such as Schwartz and Taylor, explains that nurses can also reduce stigma by leading mental health education, speaking at community events, and role modeling empathy and non-judgmental attitudes, again, in that therapeutic communication. So, in general, access to mental health care is the foundation of mental wellness, as I stated at the very beginning, and I just personally think that access is very important. So, thank you for watching and listening.